Welcome back to the deep dive. Today we are strapping in for a really deep exploration of a region that's, well, it's one of the body's largest anatomical spaces.
But it's also one of its most secretive,
Eh,
one of its most concealed.
Exactly. It's a place where major critical pathology can develop and, grow to these alarming sizes without causing any obvious symptoms until it's really far advanced.
We're talking about the retroperitoneum,
Yeah.
and specifically the immense clinical challenge posed by retroperitoneal tumors, or RPTs.
Right.
This dive is built on a stack of high-level academic sources, including some great lecture material from Dr. Senthil Kumaran, and they all emphasize the specialized knowledge and rigorous approach you need to tackle masses in this critical hidden area of the body.
So our mission today is pretty ambitious. We want to give you a comprehensive shortcut to mastering this really specialized area of oncology. We're going to try to answer three big questions.
Okay.
What are these tumors? Why is this anatomical space practically a built-in stealth cloak for disease? And what are the non-negotiable, highly specific rules for diagnosing and managing them?
And we want you to walk away from this feeling thoroughly and just quickly informed.
Let's start right at the beginning. To get there, we have to be absolutely clear on the definition. What is an RPT?
An RPT is a neoplasm, which is, a new and abnormal growth that arises from the retroperitoneal space. This space is essentially the body's expansive back wall.
The back wall. I like that.
Yeah. Anatomically, it's the area nestled firmly between the posterior peritoneum, that's the membrane lining the abdominal cavity in the front, and the transversalis fascia at the back. It's deep, it's central, and it's a highly packed region that runs all the way from the diaphragm down to the pelvis.
And the sources are really clear that while we're focusing on RPTs, statistically they are pretty rare compared to other abdominal cancers.
They are. But rarity doesn't mean low impact. Far from it. RPTs only account for about maybe 15% of all soft tissue sarcomas. However, when a sarcoma does arise here, the size, the involvement of critical structures, and the really high rate of recurrence make it one of the most challenging tumors in all of oncology.
So rare but uniquely vicious.
That's a great way to put it.
And that gets us to the fundamental paradox that really it dictates the entire clinical journey for these patients. It's the essential insight from the sources right at the start, the aha moment, that just defines the whole problem.
Exactly. Our core source, summarizing Dr. Kumar's teaching, just nails it. The line is, retroperitoneal tumors present late but appear large.
Late presentation, enormous size. That single statement just encapsulates this immense anatomical and surgical challenge. So for the next 30 minutes or so, we're going to unpack precisely why this space enables such insidious, silent growth.
And how it can turn a small tumor into a massive multi-organ surgical undertaking.
Right. And to do that, first we need a detailed map of this hidden kingdom.
Okay, let's unpack the anatomy, because absolutely everything about RPT management hinges on understanding this retroperitoneal geography.
Yeah.
It's not some open, accommodating cavern like the abdominal cavity.
Well,
It's a meticulously structured space, and it's compartmentalized by these tough, unyielding sheets of fascia.
and when you look at an image of the retroperitoneum, you realize it's less like an open field and more like a series of specialized, tightly wrapped pouches.
That's a perfect analogy.
And we need to visualize these boundaries because they are what allow the tumor to grow inward, pressing on vital structures rather than, outward where we might see it or feel it.
Precisely. The key defining structure here is the renal fascia, specifically Geroda's fascia, and all its associated fascial continuations, like Zucker-Candle's fascia posteriorly. These tough, fibrous sheets essentially partition the retroperitoneum into several distinct functional zones.
And the sources stress this compartmentalization. They call it an exam favorite.
It is, because it helps predict local tumor behavior. It tells you where things are likely to go.
Okay, so let's detail those three crucial compartments. Where do we start?
We can begin with the lateral compartment or the perinephric compartment. This is probably what most people think of first. It's where we find the primary filtration and endocrine systems.
So the kidneys and the adrenal glands.
The kidneys and the adrenal glands. A mass arising here often begins locally, maybe as a renal cell carcinoma or an adrenal mass like a pheochromocytoma. And crucially, the Geroda's fascia initially tries to contain these growths within this compartment, which often just delays the symptoms even further.
Okay, so that's the lateral compartment. Then we move to what sounds like the most densely packed and dangerous zone, the central compartment.
This is the anatomical hub. This is where all the major traffic flows.
Uh-oh.
Yeah, this compartment is absolutely critical, and tumors arising here are typically the most difficult to resect. It houses the two great vessels,
Mhm.
the aorta and the inferior vena cava, the IVC. It also contains essential upper digestive structures. The pancreas, with the exception of the tail, which kind of sits a bit more laterally, and the fixed portions of the duodenum, specifically the second and third parts. Any tumor originating here immediately poses a major threat to life. It requires mandatory vascular surgery planning from the get-go.
So it sounds like tumors in that lateral compartment might initially show up with kidney or adrenal-related symptoms, but the central compartment tumors, that's purely about structure compression and encasement.
That's a perfect distinction. The central compartment offers zero room for, benign displacement. Growth here means immediate interaction with non-negotiable critical structures.
And finally, the lower region, the pelvic compartment.
So this lower zone includes the crucial conduits connecting the torso to the lower body, the iliac vessels and the ureters, which carry urine from the kidney down to the bladder.
And involvement here would manifest as what?
Usually lower limb swelling from the iliac vessel compression or urinary obstruction. That often requires urological intervention.
So we've got this partitioned internal space. Now, let's talk about the external rigid boundaries of the retroperitoneum itself, because these boundaries are the reason the tumor can't expand outward and why we see that phenomenon of fixity.
The boundaries are tough, and they absolutely dictate the symptoms. The entire space is limited anteriorly by that thin posterior parietal peritoneum, but posteriorly, we hit the truly rigid, unyielding structures.
What are we talking about?
The powerful psoas muscle, the quadratus lumborum muscle, and the spine itself.
So muscle and bone, there's just no give there.
Zero give, none. Superiorly, the space is capped by the diaphragm, and inferiorly, it terminates at the pelvic brim.
So because the mass is pinned between the spine and psoas complex behind it and the moving compressible organs in front.
Right. Any growth forces the tumor to expand along the lines of least resistance, which is usually upward and downward, just displacing the abdominal organs.
So what does this all mean for the patient? It means the tumor is afforded this vast internal acreage to fill. It only produces symptoms when it is so large that the displacement forces reach a tipping point.
The tipping point, yeah. When the stomach can no longer expand, when the IVC is flattened like a pancake, or when the nerves embedded in the psoas muscle are finally being crushed, the symptoms are purely secondary consequences of mass effect.
Not the primary biological signal of disease.
Exactly. It's a late alarm.
Okay. With that anatomical understanding, let's shift to the tumor types themselves. The sources are very clear that when we discuss RPTs, the primary focus has to be on primary retroperitoneal sarcomas, or RPS.
It has to be. They represent the most common and clinically significant challenge in this location. They're the ones that require that aggressive surgical approach we're going to talk about later.
And within the sarcomas, one type just dominates the field. It often acts as the default diagnosis until proven otherwise.
That is absolutely liposarcoma. Our sources confirm this is the single most common RPS, comprising a staggering 40 to 50% of all cases.
40 to 50%.
Wow. Yeah, and this prevalence is directly related to the retroperitoneum being inherently rich in fatty connective tissue. That's the exact substrate required for liposarcoma development.
Which is why the teaching material has that really definitive VIVA line.
Yes. Always think of liposarcoma first in a fatty retroperitoneal mass. It's just statistical probability.
Now, we hear liposarcoma, and a lot of people might assume it's a single entity, but there's a really crucial clinical spectrum here, isn't there? The distinction between the types drastically impacts prognosis and recurrence risk.
That's a vital point.
Yeah.
The majority of cases initially present as well-differentiated liposarcoma, or WDLS. It's low grade, but it's locally very aggressive.
Okay.
But the real danger is its propensity to transform into dedifferentiated liposarcoma, or DDLPS. That's a high-grade, highly aggressive, and extremely fast-recurring tumor. And this transformation can happen de novo, or it can happen within a recurrence. The high percentage of DDLPS in the retroperitoneum is a huge driver of the severe prognosis we see.
So that explains why the need for negative margins is so non-negotiable. If you leave any residual WDLS behind, you are potentially leaving behind a time bomb that's ready to dedifferentiate and just explode into DDLPS later.
That's precisely it. Exactly. Beyond liposarcoma, we have several other major sarcoma types. For example, leiomyosarcoma, which originates from smooth muscle cells.
Okay, so given the anatomical location, where do you think the primary source for that often is?
Well, if the tumor is arising from smooth muscle in the central retroperitoneum,
It has to be the most abundant, smooth muscle tissue there, which is the wall of the inferior vena cava or maybe the aorta.
Correct. Leiomyosarcomas often have this challenging association with the IVC wall, which instantly elevates the surgical complexity because you need mandatory vascular reconstruction.
And what else?
Other key types include malignant fibrous histiocytoma, or MFH, which is now often called undifferentiated pleomorphic sarcoma, UPS. That's typically very high-grade diagnosis. And then you have rarer types like fibrosarcoma and rhabdomyosarcoma, which is more common in kids, but we do see it in adults.
Before we move on to symptoms, we should briefly acknowledge the non-sarcoma RPTs. A thorough workup needs to rule these out, right? Because their treatment is completely different.
Completely. The differential diagnosis is wide. You have to consider lymphoma, which can present as massive retroperitoneal lymphadenopathy, but that's highly responsive to chemo and radiotherapy, unlike sarcomas.
Right.
Then there are germ cell tumors, or GCTs, which almost always present as metastatic nodes from a testicular or ovarian primary. Then we have benign or low-grade tumors like neural tumors, schwannomas, or neurofibromas arising from nerve sheaths. And finally, adrenal tumors like pheochromocytoma, which requires preoperative medical management because of the massive catecholamine release risk.
That diversity really highlights why the biopsy and grading rules we'll get to are so strict.
Absolutely.
So let's tie this back to the patient experience. The tumor has been quietly growing. What are the specific, localized mass effect symptoms that finally force the patient to get help?
Well, since the retroperitoneum is so vast, the first sign is usually just a generalized, vague abdominal distension or swelling. But when the symptoms localize, they're severe.
Like what?
Patients commonly report chronic flank or back pain. But we need to understand the source of this pain. It's not pain from the tumor cells themselves.
That's pressure.
It's pressure on the unyielding structures behind it. The tumor, pinned against the spine, presses directly on the psoas or the quadratus lumborum muscles, or critically, the lumbar nerve roots embedded in there. This is nerve compression pain, and it often radiates.
I see. So the tumor is essentially acting like a growing wedge, just separating and irritating all the anatomical components it touches.
Exactly. Then you get the gastrointestinal issues. Early satiety is a classic complaint.
Feeling full quickly.
Right. This happens because the massive tumor displaces the stomach and just decreases its functional volume, so the patient feels full after eating very little. Worse still, if the tumor encases or kinks the duodenum, remember that's fixed in the central retroperitoneum or the adjacent colon, you can get a life-threatening bowel obstruction.
And given the proximity to the great vessels, I have to imagine vascular symptoms are a high-priority alarm signal.
They absolutely are. Lower limb edema swelling of the legs is a major sign of IVC compression.
The inferior vena cava.
Right, the IVC is a thin-walled, low-pressure vessel. A large, rigid tumor just flattens it easily, and that significantly impedes venous return from the lower body. This dramatically increases hydrostatic pressure, leading to visible, palpable swelling, often on one side, depending on which side of the IVC is compressed.
And finally, the urinary system must get involved.
Oh, it's common. Patients might feel renal angle fullness, a deep, palpable mass sensation in the back where the kidney sits. If the tumor fully encases the ureter, obstructing urine flow, it leads to hydronephrosis swelling of the kidney and severe flank pain.
What about blood in the urine, hematuria?
That's usually a very late-stage symptom. It signifies gross invasion into the renal system. And the unfortunate reality is that by the time a patient presents with clear, localizing symptoms like significant edema or bowel obstruction, the tumor has likely achieved a massive size, often over 10 or 15 centimeters, which immediately complicates everything.
So we have a patient, they're presenting with this vague abdominal distension, maybe some chronic back pain, maybe some lower limb swelling. We have a high suspicion for a deep-seated RPT. The diagnosis process has to be rigorous and rule-bound to maximize the chance of a curative resection later.
Absolutely.
Let's start with the physical examination. What are we looking for?
Well, the physical exam basically confirms our suspicion of a deep, large mass. The key finding that helps localize it to the retroperitoneum and distinguishes it from an intraperitoneal mass like an ovarian tumor or a large colon mass is the characteristic fixity.
We talked about this anatomically, but how does the clinician actually demonstrate this fixity on exam?
It's pretty straightforward. If you try to move the mass side to side, it will often shift slightly. However, if you ask the patient to take a deep breath, the mass moves vertically much less than an abdominal mass would.
And why is that?
Because the tumor is tethered posteriorly by the rigid spine and that powerful, fixed psoas muscle. It's essentially locked in place by, heavy-duty Velcro. This fixation confirms its retroperitoneal origin.
Okay, so beyond palpating the mass and checking for lumbar fullness, the sources mandate a very specific check, especially in younger patients.
It's a critical diagnostic rule. It saves lives, and it changes the entire treatment pathway. The rule is, always check tests in young males.
And this isn't just a physical exam technique, right? It's a differential diagnosis step.
It's a critical one.
So what's the connection? Why are we looking there when the mass is up in the abdomen?
Because the retroperitoneal lymph nodes are the primary landing zone for metastatic spread from germ cell tumors, or GCTs, originating in the testes. So a massive retroperitoneal tumor in a young man is statistically more likely to be a nodal metastasis from a small, maybe even overlooked, primary testicular cancer than a primary sarcoma.
And that's critical because
GCTs are highly sensitive to platinum-based chemotherapy. They have a dramatically better prognosis than sarcomas. Misdiagnosing metastatic GCT as a primary sarcoma and subjecting the patient to radical surgery first is a catastrophic error.
So it underscores that a sarcoma diagnosis is a diagnosis of exclusion in this specific group.
You have to rule it out first.
Okay, once the exam is complete, what is the workhorse of our investigative strategy?
The undisputed champion is the contrast CT abdomen and pelvis. It is the primary tool that defines the entire battle plan. We needed to define the tumor's precise size, its anatomical extent, and crucially, its relationship with all the adjacent critical structures. The kidney, the IVC, the psoas, the great vessels.
Why not jump straight to an MRI, given its superior soft tissue contrast?
That's a good question, and the answer is multi-layered. CT is faster, it's universally available, and it's excellent for a rapid assessment of calcification, gross fat content, and just the overall extent.
So it gives you the lay of the land.
It gives you the map. And while MRI is superior for defining soft tissue planes, the CT provides enough key tissue clues to inform the critical next step, which is the biopsy. For example, finding large areas of fat density on CT is highly suggestive of liposarcoma. Seeing the tumor aggressively encasing major arteries or having calcified components might point toward leiomyosarcoma or other less common tumors.
So CT is the essential gross mapping tool. Where does MRI offer its unique advantage?
MRI truly shines when we need to plan the technical aspects of the surgery. It is superior for a detailed evaluation of vascular involvement, specifically whether the tumor is just pushing the IVC aside or if it's actively invading its wall. And most importantly for the surgeon, it defines the surgical planes with unparalleled clarity. It helps predict if a clean negative margin resection is even feasible.
And what about PT-CT? Where does that fit in?
PT-CT is an essential tool, but it's not first line. Its primary roles are staging ruling out distant metastatic disease, and then later, critically, for evaluating recurrence. Its metabolic mapping capacity helps differentiate residual, potentially active tumor from post-treatment scarring during surveillance.
All right, let's get to the most critical, rule-bound part of the entire diagnosis, getting tissue. This is where the risk of mistake is highest. What are the rules for biopsy?
The rules are absolute. First, a core needle biopsy is mandatory. We are not just checking if it's malignant. We have to get enough material for accurate histology and, very importantly, grading. That information dictates whether the patient is a candidate for neoadjuvant therapy before surgery.
And the route of entry is paramount. Why is the rule so strict against going through the main abdominal cavity?
This is the most important clinical warning in the entire workup. You must avoid the transperitoneal route. That means you never pass the biopsy needle through the gut or the main peritoneal cavity.
And the risk is?
The risk is profound. Tumor seeding along the needle track. If you drag malignant cells across the healthy, vast surface of the peritoneum, you risk turning a localized retroperitoneal tumor into diffuse, multifocal disease within the abdomen.
Wow. So you're turning a potentially curable local disease into a generalized, incurable problem just from a single bad needle stick.
That is precisely the consequence. Therefore, the biopsy has to be meticulously planned to follow an extraperitoneal route, usually through the flank or the posterior paraspinal muscles.
And the surgeon needs to know the path.
The surgical oncologist needs to know the exact path the needle took so that the entire track, from the skin right down to the tumor capsule, can be excised en bloc later during the definitive surgery. You have to make sure no seeded cells are left behind.
It's fascinating how the biopsy is treated not just as a diagnostic step, but as the first act of the surgical resection plan.
It is. It has to be. And finally, the quality control rule. Never use FNAC fine needle aspiration cytology alone.
Why not?
FNAC gives you cells. but it's often not enough architecture or cellular volume to accurately determine the grade low versus high of the sarcoma. And because the grade dictates whether you use radiation or chemotherapy, inadequate grading compromises the entire treatment strategy. You need a core needle biopsy to guarantee you have enough material.
Mm.
So once the diagnosis is confirmed, and it's often a high-grade sarcoma, we transition to the core of the management strategy, which is driven by a single, unwavering goal.
This is that second crucial Viva line from the source material, isn't it? It sets the tone for everything that follows.
It does. Complete surgical excision with negative margins is the only curative option.
That cannot be overstated.
No. Unlike lymphomas or germ cell tumors, systemic therapies rarely, if ever, offer a primary cure for sarcomas. The goal of management is local control, and that is achieved only by getting a complete surgical resection. This requires an aggressive approach known as en-bloc removal.
Let's define en bloc removal in this context. It suggests removing more than just the tumor itself, right?
Yeah.
A lot more.
It means removing the tumor, its pseudocapsule, and a wide cuff of healthy surrounding tissue, the margin all in one piece, or en bloc. And because these tumors are so large and often infiltrate fascial planes or adhere strongly to adjacent organs like the kidney or the colon,
You have to take them too.
you often have to remove surrounding organs that are not necessarily invaded by cancer, but are simply inseparable from the tumor plane if you want to get that clean margin.
This is where the surgery becomes so radical and complex. What are some of the most common co-resections that a surgeon has to be prepared for?
The list is extensive, and it just reflects the anatomy. Common co-resections include nephrectomy, removing the kidney, often because the tumor is stuck firmly to Gerota's fascia.
Okay.
Partial colectomy, so removing a segment of the colon. Resection of adjacent muscles, like a psoas sleeve resection or parts of the diaphragm. And in central compartment tumors, the most challenging ones involve the major vessels. That often requires vascular reconstruction of the IVC or the aorta, which can involve complex patch repair or even grafting.
So this is where that philosophical shift becomes really intense. We're used to medicine trying to preserve function, preserve organs, but here, the mindset seems to be sacrifice the non-essential or paired organ if it provides a better chance of cure.
That is the critical trade-off. The clinical imperative is this: adequate margins are more important than organ preservation.
Say that again.
Adequate margins are more important than organ preservation. If a surgeon believes that leaving a kidney or a piece of colon risks leaving behind microscopic disease, those structures must be sacrificed. For RPTs, the rate of local recurrence is the paramount threat. Sacrificing a non-essential or paired structure today is an acceptable price to pay for the chance of achieving R0 status, a complete resection with truly negative margins.
Let's talk about the supportive role of radiotherapy, or RT. We know sarcomas are only moderately radiosensitive, but RT is used frequently. What is the clinical preference here?
There is a strong global clinical preference for neoadjuvant RT-SO, radiation delivered before the definitive surgery.
And why is that? What makes preoperative RT superior in this specific anatomical context?
It offers some significant advantages in the retroperitoneum. First, the tumor is in its original position, which makes the target volume clear and allows for really precise delivery that minimizes damage to surrounding tissue.
Okay, that makes sense.
Second, studies show that preoperative RT can induce a fibrous reaction, creating a slightly better defined plane between the tumor and adjacent vital structures, which can potentially make the resection technically easier.
And third,
and this is maybe the most crucial for long-term morbidity, radiating the tumor before surgery means the surgeon can often move the bowel away from the radiation field during the operation itself. This drastically minimizes the long-term risk of radiation enteritis, which is severe radiation damage to the intestines.
so postoperative RT is really reserved only for fallback scenarios.
Precisely. It's reserved for patients where the surgical margins were unexpectedly close, or where there was definite residual disease left behind because it was technically impossible to get it all. But post-op RT often requires radiating a much larger area and risks radiating already damaged tissues, making it far less ideal.
And finally, chemotherapy, or CT. Does it have a strong role in this primary treatment setting?
Generally, no. The benefit of systemic chemotherapy in primary retroperitoneal sarcomas is limited. It's not a standard upfront component for all cases, especially not for low-grade liposarcomas.
So when is it used?
Chemotherapy is typically reserved for two main situations: high-grade histology, like DDLPS or UPS, where the intrinsic risk of metastatic disease is higher, or when there is clear, confirmed metastatic disease at presentation. The standard regimens usually rely on doxorubicin-based protocols, but again, its role is almost always supportive. It's fighting distant disease or maybe improving local control modestly, not achieving a local cure.
Given the necessary radical nature of the surgery, the risk of vascular injury, the need for reconstruction, the complexity of excising multiple organs, it's very clear this requires a highly specialized environment.
Absolutely. The sources stress the mandatory nature of a multidisciplinary approach in a high-volume center. This requires a seamless coordination meeting well before the operation between surgical oncology, often two surgeons working simultaneously, radiation oncology, medical oncology, and specialized subteams like vascular surgery, urology, and sometimes even orthopedic surgery if the tumor is invading the spine or pelvis. RPT management is the definition of a comprehensive team sport.
So we've established that achieving an R0 resection is the one and only curative path. But we have to confront the immense biological reality that just defines the life of an RPT patient post-surgery, which is the high rate of recurrence.
This is the shadow that hangs over RPT management. The main post-treatment complication is the incredibly high rate of local recurrence. The figures they're stark and sobering. Recurrence rates are reported between 50 and 80% in many cohorts.
50 to 80% recurrence. That is an astonishing figure, especially after such radical surgery that often sacrifices adjacent organs for a clean margin. Why is the risk so persistent, even with the most aggressive surgical clearance?
It ties back relentlessly to the anatomy and the biology of the tumor. First, the vastness of the retroperitoneum with its multiple fascial folds and crevices makes achieving truly negative margins microscopically very difficult.
So you can be certain you have gross clearance, but...
Right, but microsatellites of tumor cells can adhere to nerve sheaths, small vessels, or fascial layers. Second, the biology of the most common tumor, leiomyosarcoma, is locally infiltrative. It tends to track along fat planes rather than pushing out a clear capsule, which makes it intrinsically harder to separate cleanly from adjacent structures.
So even if the surgeon removes the main mass en bloc, the remaining fatty matrix of the retroperitoneum is an ideal fertile environment for any microscopic disease left behind to just flourish.
Precisely. And that remaining microscopic disease, especially if it's the dedifferentiated component, grows rapidly and aggressively.
So who is facing the highest threat of recurrence? What are the key factors clinicians use to stratify that risk?
We look at three main indicators. First, histology is paramount. As we discussed, dedifferentiated liposarcoma has the highest biological aggressiveness and the highest recurrence risk.
Okay.
Second, and this is highly predictable, is the margin status of the initial surgery. If the margin was positive, so residual tumor left behind, an R2 resection, or even microscopically close, R1, the recurrence risk just skyrockets.
And the third?
Third is the overall tumor biology, so the pathological grade, the mitotic rate, the cellular aggressiveness, all of which inform the timeline of surveillance we need to set up.
Given this incredibly high and persistent risk, surveillance for RPT patients is not just mandatory, it's a long-term logistical commitment. What is the non-negotiable protocol outlined in the sources?
It is a rigorous schedule, and it's designed to catch a recurrence when it is still small enough to be surgically salvaged. That's often the only option for a recurring sarcoma.
So what does it look like?
Patients must undergo CT scans every 3 to 6 months for the first 2 years post-surgery. This period is the clinical danger zone where most recurrences declare themselves.
That's a very intense schedule. Does it slow down after that initial high-risk window?
It does,
Yeah.
but the vigilance never ends. After those first 2 intense years, surveillance typically steps down to yearly CT scans thereafter for the long term.
For the long term.
And the core teaching point, which must be impressed upon the patient, is the necessity of lifelong surveillance. A recurrence can happen 5, 10, or even 15 years down the line, especially with a slow-growing WDLS. If you stop looking, the tumor will eventually return, and it will likely achieve massive size again before symptoms force a diagnosis.
That need for lifelong vigilance really just highlights the unique nature of this disease. You aren't curing it with a single radical operation, you are imposing local control, backed by decades of active monitoring against an almost guaranteed threat of reemergence.
It's an immense commitment from the patient and the care team.
So, we have completed our deep dive into the hidden world of retroperitoneal tumors. We've mapped the vast compartmentalized retroperitoneum, we've understood the tyranny of late diagnosis leading to these massive fixed tumors, and identified the highly specialized radical surgical mandate required for any chance of cure.
Our 3 definitive takeaways for you, the learner, should be clearly cemented. First, The clinical challenge is defined by that anatomical paradox. The tumor grows huge before symptoms appear, which makes large size and involvement of critical structures common at diagnosis.
Right. And second, the only path to cure is complete surgical excision with negative margins. This forces a clear trade-off. Local control and clearance are more important than organ preservation.
And third, the statistical reality is driven by the most prevalent type, liposarcoma, and its incredibly high recurrence risk mandates lifelong, rigorous CT surveillance to ensure any regrowth is caught early enough for a repeat resection.
That emphasis on lifelong follow-up and the reliance on CT scans to find these recurring lesions brings us to our final thought for you to consider.
We know that liposarcoma, arising from fat tissue, makes up to 50% of all RPTs. We also know that the failure of management often lies in the late diagnosis and the difficulty of tracking these tumors in that vast, fatty space. This leads to massive recurrence that is often impossible to cure a second or third time.
So, if the retroperitoneum is such a vast, forgiving, and fatty space, and if the current surveillance relies on yearly CT scans catching disease that is already growing back, what are the emerging diagnostic technologies, perhaps utilizing the unique composition of this space, the high-fat content or the unique genetic signature of liposarcoma, that could allow for non-invasive earlier detection?
We're talking about techniques that might identify microscopic disease or biochemical changes before the tumor physically achieves the massive size that makes subsequent surgery so inherently radical and often futile.
It is a question of whether technology can finally give us the early warning signal that anatomy denies us.
Something to think about as you integrate this complex, specialized knowledge.
Thank you for joining us on the deep dive.
Always a pleasure. We look forward to the next one.